Hello. Am I audible?
Yes, sir. Yes, sir.
Yeah. So you are 2017 batch.
Yes, sir.
Okay. So what's your usual strength for the classes? Should we wait?
Sir, for few more minutes.
Oh yes. Yeah. So what is your clinical postings by now? What is supposed to be?
ENT and of
Okay. Okay. So you are pre-final years now. You will be appearing for your ENT, Optal, and SPM.
telemedicine.
Yeah.
Yes, sir.
This is the way of attendance. You have to message
Yes, sir. In the chat box.
chat box. That's nice. Hmm. Is the screen moving?
Yes, sir.
Can you see the second slide?
Yes, sir.
Okay. Your batch have any time visited our ortho department?
What, sir?
You had any ortho postings? Your batch
In second year.
in second year you had. Okay. Okay. Because I can't see any of you. All your videos are off. Is it a default mode or?
Sir, you can start.
Okay. Okay. Yeah. So. So our topic is going to be kind of a pediatric orthopedic topic. So we have three headings that will be. These can be three short answers, or you may have 2 mark questions and 1 mark questions. So none of this may become an essay, but it can have there's a possibility that it can be a 2 mark or a 1 mark question. So we'll be discussing torticollis first. Before that, can you identify this? What is this? Here you can see there is an anterolateral bowing of the tibia, and do you know with what condition it is associated? This anterolateral bowing of tibia. Can someone say? Am I audible?
Yes, sir. Vitamin D deficiency.
Yeah, these are the options. Sir. You have to choose from this.
The congenital pseudo.
Yeah, very good. Okay. Eh, what about this question? The tightness of the following muscles has been implicated as an etiology for congenital muscular torticollis. So, which muscle is involved in congenital muscular torticollis?
Sternocleidomastoid.
Yeah, very good. So, I think we'll just brush up. I guess you already have a very good idea regarding all this. But so, what is torticollis? So, you will definitely need to write the definition. So, the definition is lateral twisting of the neck that causes head tilt to one side and the chin is turned to the opposite side. So this is exactly the action of the sternocleidomastoid muscle. So if you have if the sternocleidomastoid of your left side contracts, you can see here this is the sternocleidomastoid, and if it contracts, your head tilts towards the left side, and your chin turns to the opposite side. So that's what is happening in torticollis. So the torus means it's a Latin word, and torus means it is twisted. Can you see the slide? Can you see my cursor?
Yes, sir.
Yes, sir.
Okay, okay. And column means neck. So there are different, there are different types of torticollis. The permanent one, temporary, and spasmodic. The example of a permanent one is a congenital torticollis. The other ones are temporary and there is spasmodic. Sometimes you sprain your neck and your neck gets deviated because of the spasm. Spasm means there's a sustained contraction of the sternocleidomastoid. So that can happen when there is an inflammation or you sprain your neck. So these are the common causes. Now, when we systematically analyzes the causes of torticollis, we can broadly divide it into congenital cause and acquired cause. And the most common congenital torticollis is congenital muscular torticollis. And that is the topic that we'll be dealing with in detail. And there can be other causes of torticollis, which can be due to bone anomalies like spine anomalies, then intrauterine postural or packaging disorders, unilateral absent sternocleidomastoid. So the opposite sternocleidomastoid overacts. So these are the congenital causes of torticollis. Then the acquired cause. It can be due to trauma. It can be due to inflammation or infection or a tumor, neurogenic. It can be due to some squint. Sometimes the patient may have ocular issues, and as a compensator to the ocular issue, uh, some persons develop a torticollis. And also otologic. When you have some ear infection, there's a chance that it can spread down and it can irritate the sternocleidomastoid again. So these are the broad causes of torticollis. So coming to the most common congenital variant, that is a congenital muscular torticollis. So this is the most common form. And how do you identify is you will find a mass palpable in the sternocleidomastoid in the first 3 months of birth. and it usually regresses by itself, and this palpable mass, and it is replaced by fibrosis. So when there is a fibrosis, there is contraction. So slowly the sternocleidomastoid contracts and it pulls the head to the same side and turns the face to the opposite side. So if you have a right-sided sternocleidomastoid involved, it tilts the head to the neck to the same side, and the chin is forced to the opposite side. So how do you get this congenital causes? So congenital means it is right from birth. So it can be due to birth trauma. There can be a history of difficult labor. It can happen during a breech delivery or a forceps application, and it is often associated with other packaging disorders. Packaging disorders is that the fetus may or the baby will not have enough space within the intrauterine environment, maybe due to macrosomia or due to reduced fluid or amniotic. Those are the packaging disorders. And there's a spectrum of packaging disorders like developmental dysplasia of hip, metatarsus erectus, CTV, etc. Coming to the pathology. So these are the causes of congenital muscular torticollis. Then come to the pathology. So what happens in congenital muscular torticollis is that, during the birth trauma, there is a bleeding into the sternocleidomastoid. And due to the hemorrhage into the sternocleidomastoid, you get a venous obstruction. And venous obstruction slowly will lead to some arterial ischemia as well. And later, this lead to fibrosis. And also another etiology is the blockage of the artery to the middle sternocleidomastoid. That also is leading to the fibrosis of the sternocleidomastoid. Then the third cause may be a local compartment syndrome. Compartment syndrome happens when there is increased compartmental pressure within a tight facial compartment, muscle compartment. So when there is for example, you get it in the legs. In the case of a fracture, both bone leg, uh, what happens is, the compartment pressure increases, and once the compartment pressure increases, the blood vessels are contracted, or it gets compressed. This leads to ischemia, and then again leading to fibrosis. So these are the pathophysiologies associated with torticollis. So the clinical feature will be like the baby will be having a small swelling in the sternocleidomastoid region. You can see here, it's like a tumor which is palpable at the birth or within 2 weeks of life. It's most commonly seen in the right side, and it can be diffuse or localized. The maximum size is usually seen in 1 to 2 months, and it usually disappears by the end of 1 year. Yeah. So if it fails to disappear by the end of 1 year, then it becomes fibrotic and it becomes contracted. And this deformity may remain like that. Again, you can see the picture here. There is a 4-year-old girl with a simple painless head tilt. So this is the signs that what you're seeing here. And there will not be much restriction of movements. And the deformity, we call it as a cock robin appearance. This is the cock robin appearance. It's a bird which tilts the head to one side. So that's why it's called a cock robin appearance. And you will find there is a taut sternocleidomastoid there. So these are the primary deformities. Primary deformities is due to the primary pathology. That is the sternocleidomastoid which gets contracted. And the action of the sternocleidomastoid is to flex the neck to one side and turn the chin to the opposite side. So that is the primary deformity. Now, if this stays there for a long time, if this is the posture of the child for a long time, for many years, then what happens is the ipsilateral shoulder becomes elevated. You can see the same side shoulder is elevated. Can you see my cursor?
Yes, sir.
Okay. And yeah, and then another thing is the baby will be lying with the head tilt for a long time, and slowly the fronto-occipital diameter is decreased. There will be flattening of one side of the skull,